I'm gonna talk probably about the most exciting presentation tonight, and that's limiting tattoos and marks. It's kind of a common question that's been going around the radiation oncology world, especially with SGRT. And how's it affecting our treatment times? How do we implement it, and the hurdles and effects that we have associated with working in a multidisciplinary environment? So, with that being said, I have no conflicts of interest. All right. Well, my background is I'm the head of physics for Hand Lab Medical Physics, and I'm the chief physicist for Radiation Oncology Centers of the Carolinas, which consists of Matthews Radiation Oncology Center and Lake Norman Radiation Oncology Center. Both of these sites use Align RT, non-integrated, but they use Align RT. Um, just a quick timeline and a breakdown of kind of where we are with Align RT and Vision is phase one at Matthews Radiation Oncology was done August 1st, 2nd through 3rd, 2016. Installation and acceptance was done the 16th through the 19th. And an additional training for the super users was additionally done then. Phase two and three training was the hands-on software training that is usually done in Maryland. And phase three training was done August 30th through 31st. It's huge importance to kind of have that kind of together in a sense, not really spread out, just so that your therapists and super users can be really, you know, aware of what's going on and not having that big gap of the software and knowledge. The main sites we are treating are prone pelvis, breasts, multi-ISIS center treatments, usually bone mets, abdominals treatments, pretty much from liposarcomas all the way to pancreas, pretty much everything. Like I said, bone mets, sarcomas, and extremity sarcomas. Acceptance and commissioning was done in accordance with TG 147. The integration, this was pretty much done with all those tests that included. For the sake of time, I think you can reference TG 147. If you're looking at SGRT, anything along those lines, I highly recommend looking at TG 147 when you start your program. The biggest thing that kind of got the confidence of me as a physicist was a bunch of end-to-end testing. The uniqueness of the system itself requires you to scan a unique phantom, something with a contour. You don't want to use something that's just your solid water in a square. You actually there's a good technique that's used where you can do it at a 45, so it can see enough surface information so the displacement calculations can calculate latitude or lateral, longitude, vertical, and all the rotational values correctly. You set up this phantom. I ultimately set up this phantom using the DICOM image to verify position, perform the offsets and angular changes to verify the dose delivered, and I obviously measured all the dose using an ion chamber. This is looking at our go live time. So if you look at this particular slide, our daily treatment time was roughly 9.3 minutes per treatment. This is using the new software on 15.1 called Untitled for varying users. This allowed me to look at over 6,000 different appointments that had associated breast diagnosis codes. So every breast diagnosis code that was associated to a treatment appointment, I was able to use that information and determine the time per month for that treatment. So as we continued through, we first started off by using Align RT and marks, and we used a lot of marks. We used a lot of straightening marks. We used medial border marks. We used pretty much everything possible to mark the patient. And then ultimately, you saw that there's a small increase, about 1 to 2 minutes per treatment. This is just as a note. This is per treatment. This is from the start of treatment when we pull that patient up and on the 40 treat to the point that we close the patient. So pretty much when the patient's leaving the room. Then we decided, our therapist, we had a good tech talk meeting, which are highly important, and we decided to pretty much, they came to me, they were like, hey, the medial border marks are coming off. Do we need them? And through the end-to-end testing and through the constant verifications that I was doing and the reassurance that we've seen through our portal imaging and our during captures, we were comfortable in pursuing that non-mark environment. Just as a side note, just because some of y'all, I know as y'all are physicists, are looking at this, I was like, hey, there was a little time increase analysis. That was actually when we were looking at 3 to 4 field chest walls and breath holds. So we were doing much more complicated stuff through the use of SGRT and Vision RT to actually be able to deliver a successful treatment, spare the cardiac heart, grab IMs when we weren't necessarily having to use an electron strip, and doing a lot more things that we were confident in our delivery. Just our common workflow in our environment is the patient is indexed to the longitudinal position. Align RT is turned on for the setup. We get the rotational values first, because if you don't get the rotational values first, you're ultimately going to fix your translations, then fix your rotations, then fix your translations, and back and forth until you continue to fight that. Um, we ultimately, upon isocenter, then next once we get everything in tolerance, we do an isocenter verification via pore films. We do place an isomark, and as I'll get to that, that's one of the hurdles. That's only for the reassurance. When that isomark comes off on our breast cases, 5 out of 6 of our therapists do not put the isocenter back on because they're confident in the align RT and the reproducibility. And then we use field light photos to capture and place into the patient's chart for our documentation. So for our workflow for our DIBH patients is we set up to the free breathing contour to remove any large rotational and translational values, and then we switch to DIBH body contour and make fine adjustments. We call in the audio commands of taking that breath and hold it, and then we port to verify our tangential ISO and make sure the patient has not moved in that process. IGRT patients, which is common in a lot of practices, is we first day of treatment we set up to our DICOM generated ROI. We make all our shifts, our rotations, our translations based off of this. We get them into an ideal position as if we were setting up any patient. We're trying to get those values perfect. Usually 2 millimeters, 2 degrees is what we work with in our clinic. Then after that point, we will image the patient, verify that there's no shifts. If there are shifts, then we'll capture a reference image at that point, and then we set up to the most recent reference image if it's a port. But also we look at the patient's DICOM image as well to make sure that we weren't introducing multiple errors along the path. So multi-isocenter states. This is kind of something that I love. It gives you the information of multiple isocenters. It allows you to know that you're in the right position on the right vertebral body. We recently started implementing it and setting up for multiple iso treatments for the bone mets. Advantages, like I said, it validates the appropriate treatment site. It's safety. I mean, that's what we strive for, right? We want to make sure that we're treating those patients efficiently and safely. And if we can use the software like it's supposed to, then we can do this to our maximum ability. Smaller shifts due to the ability to eliminate large rotations. And then we use the field light photos. So we're getting the patient down much faster off that table if they have multiple bone mets that we're treating. They're not having to sit there, wait for us to draw field light borders on, or field borders on and everything like that. So to put in the chart, instead we just capture this image and then we can continue on. This comes to the question: why tattoos, why marks? Um, I was looking a lot of like blogs up, just kind of seeing what the consensus of patients around the world had regarding tattoos and marks. And this one patient said, "Did anyone get radiation tattoos or just markers on the skin?" Not really liking the idea of tattoos they suggested. And that's kind of the consensus as you go to these SGRT forums and go and actually talk to your patients. You find that there is a little bit of a reservation there. They don't always say it, but I bet if you started polling your patients, you would find that it actually is pretty consistent. Um, Print's small here, but ultimately, this lady's asking, about pretty much saying that her rad onc did not want them to use tattoos, so they do marks. But their therapist would prefer tattoos, which I'm not sure. I'm not a therapist, but I would hard to believe it because they're probably not using an SGRT or a Vision RT system. So from that point, I mean, the questions are getting asked, the patients are wondering, and in this particular instance, it's hard to conceal. I think as we're getting into the warmer months, patients are kind of conscientious of what's going on and where they're getting treated, and not wanting people to know outside of those radiation oncology walls what's going on in their lives. So, as I said, the advantage is no longer have to conceal marks from others. We've had multiple patients, specifically at my clinic. We're predominantly breast cancer driven clinic, and we've had multiple patients who want their marks off, who we had to keep marking, or we had to do something to limit the number of marks we were using. Because as I told you, we were using a lot. We were trying to be overly cautious, probably at the expense of the patient's mental status. I mean, I just, it's amazing what Vision has done at our center. But another thing is tattoos are for a lifetime. They're a visual reminder of the treatment. I mean, that should resonate really, really well in here. I mean, they're a tattoo. Yeah, it's a small dot, but there's a lot of places that put a lot of small dots on a patient, from leveling marks to ISO marks to everything, and medial border marks. The question is are they necessary? And I mean, I'll leave that for you to decide, but I hope my presentation can help kind of guide you in a direction. Accuracy and safety. This is where being an RSO in my clinic. I'm driven towards the safety of patients and the delivery, the safety of treatment, and this gives us, a patient-specific contour ROI that we can use for setup that is not 3 points. It gives us a map of a patient, which is 20,000 points that we can confine to an ROI that we can accurately position the patient on that is specific to that patient. And we get to also know if changes are happening during treatment. The advantage is cost. Paint pens and tapes go down. I know some places have to use individual paint pen per patient. So, that's always a struggle. And, well, guess what? You don't have to use paint pens, which your department director will love you when they hear that. Efficiencies, cut down the patient time. Patients being treated from the point where we're called back. We no longer have to draw and field borders. We can quicker setups and ISO setups, and we're not really compromising the safety. We figured that out through our imaging, through during captures, through multiple imaging. Hey, this patient moved, let's image again. We knew that they moved that amount that we were seeing on a line RT. This is one example of a breast case, a right-sided breast case. For y'all that are using SGRT or Vision RT, we really like this idea of called upstream and downstream effect. We utilize treatment captures beyond the normal use, I think, of most clinics. We're using treatment captures pretty much for every single patient multiple times. And this is done mainly, I keep thinking it's behind me. We do this mainly to rule out the large rotational values of the patient that are much further downstream so that we can position the patient with smaller ROIs and a much more efficient ROI when we're monitoring them. Like I said, this eliminates the ROI sizes and the lag time, and it allows us to confirm appropriate rotations of the patient. Some advice I would give is inclusive training. Continue to train your therapist on software. Don't just think it's one and done type deal that you're using it every day. There's usually how it goes is you have one therapist, two therapists, three therapists that really get it, then your other one hides behind them. Every therapist needs to kind of be brought about. Okay, and then include your therapist on the end-to-end testing. This is kind of where they get the confidence in what you're saying and doing is what they'll be doing on the treatment machine. If you include them on your end-to-end testing, then they'll get a better understanding of what's going on. And then reestablish the basics. How effectively look at a treatment capture, which can be a complicated thing, the green versus the pink. How to edit ROIs, and the differences between the VRT and the DICOM and real-time monitoring. The differences in how to correct those differences. Um, Another question that comes up is, what if we have to treat these patients again? That's a great question for a long time ago, in my opinion. But record and verify systems have become more robust. Documentation requirements via accreditation standards have increased. Ability to capture high-resolution images of the patient-specific documentation. Reproducibility of treatment plans using DICOM information, just deformable image registration alone. We could not do this a long time ago or do it efficiently, but now we can, and we can do it effectively. Like I said, some final advice, end-to-end testing, do a lot of it. Don't just do once, don't just do it twice, do a lot of it. I actually had enjoyment because I got to learn the software even better by doing a lot of end-to-end testing, and my therapist did too. Don't remove all your marks at once. Maybe start with the breast, or maybe start with just your medial border mark. But eventually, I think once you start removing one, you'll start to remove them all. And that is the end of my presentation.
Thank you.